Hello, I'm Dr. Rajiv Kumar, the Medical Director of the Rocky Mountain Movement Disorder Center and the Huntington's Disease Society of America Center of Excellence in Englewood, Colorado. I've been working with patients with tardive dyskinesia, or TD, for more than 20 years. Today, on behalf of Teva, I'll be speaking about clinical symptoms and treatment of TD and its differentiation from drug-induced Parkinsonism, or DIP. Movement disorders in patients taking antipsychotics are common, and up to 1/3 of them will develop either TD, DIP, or both. I'll be focusing on how these two disorders may be misdiagnosed and how treating a patient with TD for DIP could have adverse consequences for the patient. I'll also speak about how the opposite is true as well. Tardive dyskinesia and drug-induced Parkinsonism are both very common movement disorders, and both are caused by dopamine receptor blocking medications, like antipsychotics. However, they present differently, differ in their pathophysiology with respect to dopaminergic signaling, and have different treatments. In fact, treatment for one disorder may worsen the other. The term EPS, or extrapyramidal symptoms, has been used in psychiatry for many years, and this term has been propagated by the labeling of medications by the FDA. Historically, EPS has been used to describe all drug-induced movement disorders experienced by patients taking antipsychotic medications. As a result, there's been the indiscriminate treatment of both disorders with anticholinergic medications. We now know that the term EPS is outdated. It's very important to differentiate between the disorders because they merit different treatments. The use of antipsychotics has markedly increased over the past 2 decades due to expanded indications for use in mood disorders, such as depression and bipolar disorder. The data suggests that in 2022, 8.7 million Americans received prescriptions for an antipsychotic, and as a result, we estimate there are at least 785,000 individuals who have TD in the United States. Now that's a shocking number, and even more surprisingly, at least 85% of patients have been misdiagnosed or remain undiagnosed. Many of these individuals who have been misdiagnosed have been labeled as having EPS, and many of them in fact have DIP. So this means that about 15% of patients have been diagnosed, and only 6% of individuals have been treated with a VMAT2 inhibitor. If we look at U.S. healthcare claims data of those individuals who have been diagnosed with TD, about 36% of individuals are receiving benztropine, with about 3/4 of these individuals having received benztropine for more than 3 months, and about 1/3 having been treated for greater than a year. And if we look at online surveys of psychiatry providers, about 40% of individuals indicate they would actually initiate benztropine to treat TD, which is an unfortunate failure of our ability to educate these providers. So, for patients suffering from TD, the lack of an accurate diagnosis can lead to mistrust and frustration. And of course, for patients that have been misdiagnosed, the wrong therapy can result in a worsening of their symptoms. As a result, patients can fail to seek care because of their frustration and may not follow instructions correctly. Let's talk a little bit about the underlying mechanisms of disease for both TD and DIP. And then we'll review some videos that could help one make appropriate diagnostic and treatment decisions when seeing patients with drug-induced movement disorders. First, let's talk about the time course of TD and DIP. DIP occurs due to acute blockade of predominantly dopamine D2 receptors. Now, because of this blockade, we get a reduction in postsynaptic dopamine signaling. Tremor, bradykinesia, rigidity, and impairment of gait may become apparent within the first few weeks or first few months of starting or increasing the dose of the antipsychotic. In tardive dyskinesia, the term tardive means delayed. Chronic blockade of dopamine receptors by antipsychotics results in delayed upregulation or supersensitivity of these postsynaptic dopamine receptors. So TD usually develops after months or years of exposure to antipsychotic medications. Let's review the clinical features of DIP and TD and see how they're differentiated when we examine patients. The degree of movements is one of the first things I look for. This patient with DIP has a masked face with reduced facial expression and reduced blink rate, which is different from the typical normal level or increased level of facial movement we see in TD. This patient also has mildly flexed posture, reduced arm swing, reduced stride length, reduced speed, and multi-step turns, all of which are characteristic of Parkinsonism. The nature of movements in DIP and TD are also different. When patients with DIP have abnormal movements, it is rhythmic. This elderly gentleman has typical 4 to 5 Hz resting tremor in the left hand, and it is not uncommon for the tremor to improve during sustained action and posture, but it may persist. You can see this with the postural tremor in this gentleman's right hand. And in fact, if we allow the jaw to hang down, he has synchronous tremor of his jaw. TD is characterized by excessive movement or hyperkinesia. This patient has continuous movements of the neck, jaw, and face. We can see she has quivering movements of the lips. In addition, she has excessive right shoulder elevation and right head tilt. This patient has undulating movements of the lips, occasional tongue protrusion, and excessive blinking. This younger woman has excessive lip pursing, platysma contraction, frontalis activation, and eyebrow elevation. This patient has tongue movements that are unique. They go back and forth, then to one side of his mouth. He has very severe back and forth movements of his tongue, which are unpredictable, and in fact, you can see that he has involuntary jaw closing and briefly bites his tongue. This patient's TD movements are irregular, jerky, and unpredictable. This patient has severe, generalized choreiform movements with piano-playing movements in the fingers and the toes, body rocking, and facial dyskinesias with grimacing, and we can see the protrusion of his tongue within the mouth. Let's look at the upper extremity muscle tone, which is a component of the AIMS examination. First, we examine rigidity at the level of the wrist by isolating the wrist and passively moving it. Then, we examine the tone at the level of the elbow. Now, if you do not detect increased tone at rest, have the patient open and close the other hand while examine the tone again at the level of the wrist and the elbow. We should do this for each side of the body independently. As you can see, I can easily move this TD patient's arm at the level of the wrist and the elbow without resistance, both with and without activation of the contralateral hand. Performing the same maneuvers on this man with Parkinsonism, you can see that I don't have difficulty moving his wrist, but there is a resistance that occurs when I attempt to flex and extend his elbow. Now, this is something you predominantly feel, but here you can almost see that I'm having some difficulty extending his elbow. To make an accurate diagnosis of TD, it is essential that we are able to carefully assess and differentiate TD from DIP. Because if one makes a misdiagnosis and prescribes an anticholinergic to a patient with TD, you may exacerbate the hyperkinetic movements by increasing dopaminergic signaling. On the other hand, if you prescribe a dopamine-depleting VMAT2 inhibitor to a patient with DIP, you further reduce the patient's already low level of dopamine, and this can worsen the patient's features of Parkinsonism. So it's important to differentiate TD and DIP by careful observation and examination of the patient. With the correct diagnosis, we can render the correct treatment. Thank you for watching, and I hope what I've shared today will help you in the assessment of your patients with movement disorders who are taking antipsychotic medications.